بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما يا كريم. اللهم اجعلنا ممن يستمعون القول فيتبعون أحسنه وأدخلنا برحمتك في عبادك الصالحين. Dear colleagues, this is one of the topics that are now ready to be discussed, which is concerning with the imaging of metabolic bone disease. And we will have this topic in two separate lectures. I will start by the first one, and I will show to you the items for discussion. Actually, the metabolic bone diseases are many, and we are going to talk about osteoporosis, osteomalacia, rickets, and hyperparathyroidism, as well as renal osteodystrophy in the first part of this talk. Then we will discuss later on the scurvy, gout, pseudogout, ochronosis, acromegaly, Paget disease, Gaucher's, osteogenesis imperfecta, and osteopetrosis. Then in osteoporosis, we may have some side issues to be handled, like the systemic osteoporosis, regional osteoporosis, migratory osteoporosis, as well as the reflex sympathetic dystrophy, which was known previously as the Sudeck's atrophy. Then, as you all know, that calcium is very important for the maintenance of normal cellular function, and the serum calcium represents about 1% of the total body calcium. The serum calcium is regulated by three major factors. Number one, the parathyroid hormone, the vitamin D, and the calcitonin. The maintenance of the normal serum calcium is dependent on the intestinal calcium absorption, renal excretion of calcium and others, skeletal mobilization, and the calcium uptake. Then this is just a scheme for how the vitamin D is sensitized in the human body. Actually, the main sources for vitamin D are the skin from the sunlight and the diet. These two main sources provide the pre-vitamin D, which is known as D2 and D3. The provitamin D is transformed into the liver into an intermediate form, which is known as 25-hydroxy vitamin D. And by another mechanism, it is transformed into the active form of vitamin D in the kidney, and this active form is known as 1,25 dihydroxy vitamin D. And this is the active form which is involved in calcium phosphorus homeostasis and the bone remodeling mechanisms. Then after that, the excess of vitamin D is catabolized into the inactive forms. And this is what I have mentioned, that you have two main sources, the ultraviolet rays from the sun in transforming the raw material in the skin into vitamin D3, and you have by food the vitamin D2. Both are activated in the liver, then in the kidney, and until finally you have the active form, which is involved in the bone remodeling mechanism, and the excess is catabolized. Then in the kidney, this enzyme activity is strictly controlled by the serum calcium. Then looks let us look what happens if there is decrease in the serum calcium level. What do we mean by hypocalcemia? In cases of hypocalcemia, there is increase in the production of the parathyroid hormone, and this will increase the activity of 1 alpha hydroxylase enzyme in the kidney, and this will increase the circulating vitamin D by one of three mechanisms. Number one, stimulation of the osteoclasts to release calcium from bone, stimulation of intestinal calcium absorption, and the reduction of the renal calcium excretion. Then, what do we mean by osteoporosis? Osteoporosis means that there is decrease in the bone tissue mass and per unit volume. And then this means that if you look here and you see this is the normal trabeculation of the bone, and here is the osteoporotic bone. Porotic means that there are pores inside the bone that are devoid of osseous material. Then osteoporosis is usually measured by many mechanisms, and the WHO defines osteoporosis as a T-score less than minus 2.5 standard deviation, as I will mention in a moment. This is quite different from osteomalacia, which means that there is bone softening, meaning that there is no enough calcium in the bone, and this is the basis of vitamin D deficiency. Vitamin D deficiency will lead to osteomalacia, while decreased serum calcium may lead to osteoporosis. Then osteoporosis can be classified into primary type and the secondary type. The primary type is divided into two: the postmenopausal type, which is seen in older females, and it affects the cancellous bone in particular, and this type appear in the spine and near the wrist joint. While the senile osteoporosis, which is seen in elderly people, and it affects the cortical and the cancellous bone, and the manifestations are usually seen in the proximal part of the humerus, in the tibia, and in the pelvic bones. The secondary type of osteoporosis is due to an abnormality in the metabolism, like in endocrinal diseases, in cases of inflammation. Some cases may follow trauma, and the medication by this particular drugs or the corticosteroids, which are known to induce osteoporosis. Then, what are the manifestations of osteoporosis in the skeleton? Usually, the osteoporosis will appear in the vertebral bodies, in the proximal part of the femur, in the calcaneus, and in other areas like the proximal part of the humerus and in the pelvic bones. It is well known that more than 40% of bone loss is required in order to see osteoporosis in the plain films. And actually, will be quite evident in the spine in particular, where you may appreciate the decreased bone density and the decreased thickness of the cortex of the bone and loss of the primary trabeculae inside the vertebral body. And this is also seen in the plain films and the CT scan, and you may appreciate the changes in the MRI after the occurrence of vertebral fractures. First, you see penciling of the vertebrae due to loss of the trabecular bone or loss of bone density. Then you got what looks like the picture frame vertebra. The cortex is well appreciated while the bone density in the vertebra is markedly lowered. Then Loss of the trabecular bone may lead to ghost vertebra, and finally you reach the compression fracture and the vertebra plana. Then these are the methods for diagnosis of osteoporosis, like loss of the trabecular bone in the proximal part of the femur, thinning of the cortex of the tubular bone, and this is known as the metacarpal index, which means that the cortex, the thickness of the cortex of the metacarpal bone compared to the thickness of the medulla, which mean osteoporosis is diagnosed whenever you got more than 25% loss of cortical thickness. Then these are the ways of bone mineral density measurements. They include radiographic absorptiometry, the single photon and the X-ray absorptiometry, and this very popular technique, which is the dual energy X-ray absorptiometry, or the DEXA. Then the DEXA can use two ways of measurements. The first one, which is popular, is the T-score, and the second one, which is not popular, is the Z-score. By the T-score, this means that there is a standard deviation compared to the mean bone mineral density of young adult. Then you measure the bone mineral density and you compare it to a normal young adult, then you got the T-score. And by the Z-score, there is a standard deviation of an age matching. A volunteer of the same age and the same sex to the patient who is not complaining of any symptoms related to osteoporosis, and this is the score. Then the T-score, as stated, were based on WHO measurements. If it is in the range of -1, that's to say that you are here in this area, and this is normal. If you go lower down from -1 to minus 2.5, then this is osteopenia. If you go below 2.5, then this is osteoporosis. And the osteoporosis is considered severe if the T-score is more than -2.5, and at that time there is a greater risk of fractures. And these are the advantages of DEXA. It is a rapid technique of relatively lower cost and low radiation risk, and has the ability to use this index, which is the fracture risk assessment tool, by which you can predict if this patient is at a risk for developing a fracture or not. Then the disadvantages of DEXA are many. The area of bone mineral density that is measured by DEXA account for only 60 to 70% of the bone strength, and that means that the readings of DEXA do not express the real bone mineral density of the overall skeleton. And DEXA does not distinguish between the cortex and the trabecular bone. It can result in overestimation, especially in larger bones, and of course in smaller bones it may result in underestimation. Overestimation may occur if any high density object is present in the path of the radiographic beam, like arterial calcification, fractures, metal implants, vertebral end plate bone sclerosis, osteophytes, for example, in degenerative disease. And on the contrary, laminectomy will result in underestimation of bone mineral density. In children less than 19 years old, These children have not reached the peak of bone mass, and the reliable data can at that time be obtained via the Z scores. Improper positioning and the numbering of the vertebrae and the detection of bone edges may result in abnormal interpretation. The presence of internal stents and external objects like buttons can interfere with the interpretation. Then also you cannot interchange the data with DEXA with other people in other countries, for example. And if you look to this lateral X-ray of the lumbar spine, and you see that there is evident osteoporosis in the form of marked decreased bone density of the cancellous bone, thinning of the cortex, and multiple vertebral fractures manifested by loss of height of the affected vertebrae. And we used in interpretation of these films, we used to say that there is partial loss of height or partial collapse of so and so vertebrae, but it is better to say in frank words that you are dealing with an osteoporotic fracture so that they can deal with this. If you say evident loss of height of the vertebra, then you should say that you are dealing with osteoporotic fracture. And the vertebral fracture should be diagnosed when there is loss of height in the anterior, middle, and posterior parts of the vertebral body, which is more than 20% of the vertebral height, and there is grading. The fracture is considered mild if it is in the range between 20 and 25% loss of vertebral height, moderate up to 40% loss of vertebral height, and severe osteoporotic fracture if there is more than 40% loss in the vertebral height. And this is a fracture in the L1 vertebra with more than 40% loss of the vertebral height with anterior wedging, and you see here in the above and the below disc spaces, and the DEXA results in this patient were normal. But here you can easily appreciate the osteoporotic changes and the osteoporotic fracture as well. Then these fractures may be called the insufficiency fractures of the spine, and this is in appearance of the vertebral fracture, and after some time you got more vertebral collapse, more depression in the vertebral end plates. And these fractures can also be evaluated or graded by MRI. And you see this is L5, 4, 3, 2, and 1, and this is L1 vertebral collapse, vertebral osteoporotic fracture with anterior wedging. And of course, many of these fractures will show a change in the bone marrow signal, because this is actually a sort of trauma, if it is minor trauma or major, but there should be some bone marrow edema in the vertebral body, as you can see here. Then one of the ways to treat these fractures is the vertebroplasty. We inject, guided by imaging, the cement material in order to support the vertebral body, preventing further collapse. And this is an osteoporotic fracture at L4 vertebral body. It is considered mild. You see minor degree of loss of height of the vertebra, and the changes in MRI or bone marrow edema and loss of height. Then this is the vertebroplasty. And this patient with severe inflammatory bowel disease and treated by corticosteroids developed extensive osteoporotic changes in the spine with multiple vertebral fractures that are treated by vertebroplasty. Then we came to the osteopenia or regional osteoporosis, and this may be the sequelae of immobilization or paralysis, or the sequelae of this syndrome is known as complex regional pain syndrome or reflex sympathetic dystrophy or the Sudix atrophy. This syndrome is almost of unknown etiology, but it is well documented after trauma and some cases after myocardial infarction and so on. Then infection may lead to such an appearance. Transient osteoporosis of the hip is one of the regional osteoporosis. And if this osteoporosis is migratory, meaning that it affects multiple joints at different times, then you know it is known as regional migratory osteoporosis. Osteopenia is also seen in rheumatoid and other joint diseases, and also in the lytic phase of Paget disease, as I have mentioned in the second part of this lecture, and in early cases of bone infarction, you can see this. Idiopathic Idiopathic transient osteoporosis is a self-limiting disease of unknown etiology, and it appears in the X-rays as decreased bone density, which may not be appreciated well in the X-rays. But on MRI, which is the modality of choice for diagnosis, you got bone marrow edema, low signal in the T1 and high signal in the T2 and the STER, and this is confined to a bone or near one of the joints, commonly seen in the hip, but can be seen in the knee and in the ankle as well. Then this disease affects the males in the range of 45 years of age, and the male to female ratio is 3 to 1. And at a time, a single joint may be affected, and this is commonly the hip. But if the disease affects two or more joints, it should be known as regional migratory osteoporosis. And here, if you look to the plain X-ray of this patient, you cannot appreciate any significant difference between the left and right hip. Then in MRI, the right hip joint showed the head of the femur and the neck as well showed low signal in the T1 and high signal in the STER images. And if you look carefully and you see a linear low signal shadow here below the cortex of the femur, which represents a subchondral fracture. And there is suggestions in the literature that supports that the presence of a subchondral fracture plays an important role in the pathophysiology of this condition. Then you may consider that the fracture is the initiative of this significant bone marrow edema affecting the head and the neck of the femur. In the plain film, you may hardly appreciate some decreased bone density unless it is evident, and you can see significant difference between both hips. The joint space is preserved, and you may see the distension of the joint capsule by displacement of the fat planes around the joint, indicating the presence of joint effusion. It's important to know that this disease is self-limiting and it may resolve completely without treatment in the range of 6 to 8 months. Then this patient with migratory osteoporosis uh, first presented by lesion in the knee joint, low signal in the T1 and high signal in the STER, and this is the CT scan of the same patient 8 months later. He cannot appreciate any lesion. And in the region of the condyle, you see normal bone trabeculae with no evidence of osteoporosis. But later on, the patient developed some regression in a part of the lesion and progression in another part to involve the intercondylar area and to extend into the opposite femoral condyle, which is also seen in the axial image. Later, the patient developed also a third lesion in the talus. You see here, there is low signal and the talus in the T1 and high signal in the stair, and you see some fluid around the affected bone. Then we came to the reflex sympathetic dystrophy syndrome, which is previously known as Sudix atrophy and now is known as complex regional pain syndrome. This is a rare disorder and the exact etiology is not known, and the presentation is usually by a swollen, red, extremely painful limb, let us say the foot or the hand, for example, and this usually follows a trauma which is usually minor trauma, not usually leading to a fracture, for example, but sometimes there is a fracture and the fracture is well managed, but the patient passed into this syndrome and there is no cause in many of the cases, and some cases have CNS disorders, myocardial infarction, and some may be immobilized for a certain time. Then in the X-rays, and you got severe osteopenia in the periarticular area, and you may see the underlying etiology if you look carefully here and you see a fracture in the distal part of the radius. Together with osteopenia, there is soft tissue swelling, as you see in the photograph, and after that you got soft tissue atrophy. Supraosteal bone resorption may occur and the joint spaces are not affected. This disease should be carefully differentiated from disuse osteopenia, which is the osteoporosis following fixation of a fracture, for example, or disuse for another etiology. And this disuse osteopenia requires aggressive physical therapy to be resolved. Then in reflex sympathetic dystrophy syndrome, MRI will show soft tissue edema and enhancement with skin thickening, and later on you got soft tissue atrophic changes, and in the bones you get patchy bone marrow edema, low signal in the T1 and high signal in the T2 and the stir images. The nuclear medicine will show increased uptake in the affected part of the limb, and this increased uptake is usually juxta-articular or around all the joints and is considered as a diagnostic finding for this syndrome. An MRI, and you got bone marrow edema of the talus, and this is low signal in the T1 and high signal in the stair images. And this is also stated in the literature that normal MRI does not rule out the presence of reflex sympathetic dystrophy, and this will depend mainly on the appearance of the foot. If you feel that the foot is swollen, it is red, and is very, very sensitive to touch, then you know that the patient has passed into this particular syndrome. But if you look to this MR images, edema of the talus may be considered the sequelae of trauma and it will resolve after that. And the edema of the talus is also one, or let us say, a stage one of avascular necrosis, if you remember, of the talar bone, to be followed by the appearance of a line, then separation of the bone, and so on. But in order to separate these three items, post-traumatic edema, early stage of avascular necrosis, and the reflex sympathetic dystrophy, it is the clinical which is very helpful in this. Then this is once more the appearance of reflex sympathetic dystrophy in the foot with a significant increase uptake around all the joints, the metacarpophalangeal, interphalangeal, intercarpal, and so on. And by the plain film, especially in advanced stages, and you got marked decalcification of the bone with decreased bone density, which cannot be differentiated from disused osteoporosis or even osteoporosis due to ischemia, for example. But it is, as I have mentioned, the clinical, which can easily differentiate. And this is complex regional pain syndrome in the left hand. Then you see the severe osteoporotic changes around the joints, around the carpal bones, and in the proximal, in the distal part of the ulna and radius. And if you look carefully, you cannot see any fracture line, for example, in this particular case, and you compare to the normal hand on the left side. This is the right hand. Then here you can see a fracture in the distal part of the radius with extensive osteoporotic changes in the hand. One may say that these osteoporotic changes may be due to disuse because of the fracture and the fixation and so on. You are right, but the clinical will differentiate, the appearance of the hand will differentiate between both. And this is the classic appearance of the foot with reflex sympathetic dystrophy, and you can see subtle changes in the MRI. This patient is diabetic and fell off her bicycle and injured her right foot. The X-ray showed the calcaneal fracture, and 6 weeks later, the foot becomes swollen, hot, and extremely painful, as you can see here. But the fracture is not seen because the calcaneus is not well presented in this image. Then we move to the osteomalacia, which means that you are dealing with bone softening, and this will be the result of vitamin D deficiency. And as I have mentioned, vitamin D is essential for the calcium metabolism in the human body. And if you go to the laboratory findings, the serum calcium may be slightly decreased or normal. The serum phosphorus will be decreased. The serum alkaline phosphatase will be elevated. And all causes that can lead to vitamin D deficiency are involved in the development of osteomalacia, like dietary deficiency of vitamin D, lack of sunlight exposure, deficiency of vitamin D metabolism. The most common cause is the chronic renal disease or renal failure. Also, renal tubular disorders, X-linked hypophosphatemia, chronic liver disease. The liver is also a part in the metabolism for activation of vitamin D in the human body. Administration of phenobarbital, the decreased absorption of vitamin D in the intestine, like in cases of malabsorption syndrome, and partial gastrectomy. Also decrease the position of calcium in the bone because of some of the drugs like diphosphonates, which are used for the treatment of Paget's disease. There are two only manifestations for osteomalacia in the skeleton. Number one is bone softening. Number two is the loser zones. By bone softening, and you see this is the pelvis, and you got the marked softening of the pelvis with protrusive acetabular on both sides. But if you look to the bone density, it may appear normal, and there are deformities because of the that the bone is now soft. The important deformity is what is known as protrusive acetabuli, meaning that the femur is centrally protruding through the pelvic due to softening of the pelvic bones. Kyphoscoliosis due to softening of the spine, increase in the blade concavity, what is known as codfish vertebrae, and bowing deformity of the long bones. And the second major manifestation of osteomalacia is the loser zone. And the loser zone is a pseudo fracture or an insufficiency fracture, which is typically located at certain points. And these points are usually the concave or the compressive side of a bowing deformity, and is frequently seen in the pubic and ischial rami, the medial aspect of the femoral neck, the ribs, and the scapulae. They are usually perpendicular to the long axis of the bone, and this is the long axis of the femoral neck, and you see this loser zone, which represents a radiolucent band surrounded by a little area of bone sclerosis. This is what is known as the codfish vertebra. The vertebral body is soft and the disc is healthy. Then the disc material will compress the end plate from below and from above, and you got finally the appearance of a codfish vertebra. And there are here loser zones in the iliac, in the inferior pubic ramus, and loser zones also in the medial aspect of the femur that are typical of osteomalacia. And also the lateral border of the scapula and the medial aspect of the femur are common sites for loser zones. Then rickets is the osteomalacia of the children. And the same causes of osteomalacia can contribute to the development of rickets, and the vitamin D deficiency in the pediatric age group may result in skeletal changes of rickets that are usually seen by the age of 2 years of life. The deficiency of vitamin D, which is the active form 125 dihydroxyvitamin D, or deficiency of calcium, or deficiency of phosphorus, alkaline phosphatase, or the presence of abnormal body pH. Then deficiency of mineralization of the bone is seen at the metaphyseal zones of provisional calcification, the end of long bones. And this will affect the gross plate at particular sites, especially the knee, the wrist, and the anterior ends of the ribs, which are swollen. All these areas are swollen, and this is known as rachitic rosary beads. Bowing deformities can also occur due to softening of the bone, and this is noticed when the child is walking, and sometimes the ribs may be drawn inward by the diaphragmatic muscles, and this is known as the Harrison sulcus. Then what happens, and there is improper mineralization of the zones of provisional calcification, then you got a broadening of the metaphyseal ends of long bones, cupping and the fraying of the end of the bone, and these are classic features of rects. And here you see the changes in the distal part of the ulna and some changes in the radius, and also you got some changes near the knee joint. And here the active rickets is evident in the distal part of the radius and ulna, and also you got the rachitic rosary beads, which are widening of the provisional zones of calcification at the costochondral junctions, leading to these swellings, which are known as rachitic rosary beads. And you may remember the changes of rickets by these abbreviations, which are, in my opinion, they are difficult to remember, but it is just written here for anyone who would like to follow. And here you see that these are the abbreviation or the letters of rickets. Reaction of the periosteum, meaning that there is periosteal reaction in distinct cortex, coarse trabeculation. The knee, wrist, and ankle are predominantly affected. Epiphyseal plates are widened and irregular, and there is tremendous metaphysis, means that the metaphyseal end of the long bone is swollen, and this is clinically seen with cupping and fraying. Then you got a spare metaphyseal spares like this, and you got prominence of the metaphyseal end of the long bones. And this is typical appearance of rickets, and you see cupping, fraying, enlargement, swelling of the metaphyseal ends of the long bones. Deformities are also seen due to bone softening, similar to other adults, and it also seen in the children. And, in the course of deformity, you may got fractures, and this is a relatively old fracture with some callus formation around the site of the fracture. If you give treatment for rickets, the calcium starts to deposit in the provisional zones of calcification, and you got metaphyseal lines of increased density, meaning that rickets is healing. And after complete mineralization, and you say that this is healed rickets, which will return to the normal appearance of the bone. In this part of my talk, this is the final issue, which is the hyperparathyroidism. Hyperparathyroidism means that there is excess parathyroid hormone in the body, and this may be due to primary causes, secondary, and tertiary causes. The parathyroid hormone level is increased, and this will lead to osteoclastic activity, meaning that removal of calcium from bone. And this have certain pathognomonic appearances in the skeleton. The causes of hyperparathyroidism, the primary hyperpara is in most of the cases secondary to the presence of a parathyroid adenoma, but parathyroid hyperplasia and carcinoma, which is extremely rare, may lead to also hyperparathyroidism. The secondary hyperparathyroidism means that the parathyroid is active due to chronic hypocalcemia because of the renal disease. The kidney is diseased, and too much calcium is going through the urine, then the calcium level will be decreased, and this will be reflected on the parathyroid gland to start to secrete the parathyroid hormone to mobilize calcium from bone to cover the deficiency. Then this is known as secondary hyperparathyroidism. And the tertiary hyperparathyroidism is means that the parathyroid function is now without any control, and it is autonomous, working continuously to produce parathyroid hormone, and which will lead to the skeletal manifestations, as I will mention. Then hyperparathyroidism will result in resorption of the bone, of the calcium from the bone to be transferred to the blood. And the resorption will start in these particular areas: the subperiosteal bone, the subchondral bone, the subligamentous bone. In the subperiosteal bone, this is quite evident in the hand, in the proximal and the middle phalanges of the second and third fingers, especially the radial aspect of the phalanges. Also in the medial aspect of the tibia, femur, and the humerus, and also in the lamina dura of the teeth. If you look here for normal tooth, and you see a very fine line of calcium that is bordering the root of the tooth, and this is known as the lamina dura. In cases of hyperparathyroidism, this calcium is very friable and it will be absorbed. Then you got loss of the lamina dura, which is, as stated here, is a non-specific sign. Then subchondral bone resorption will appear in the lateral end of the clavicle, in the symphysis pubis and sacroiliac joints. Subligamentous bone resorption in the ischial tuberosity, in the trochanterus, and the inferior surface of the calcaneus. Then this is a very good example of what I mean by subperiosteal bone resorption. This is the normal appearance of the phalanges and the metacarpal. And here you can see that the resorption of the bone in the phalangeal tuft, and also with what is known as intracortical resorption. And you see some areas of radiolucences through the cortex of the bone. Look at the intact cortex of the bone here, but here you hardly appreciate the cortex, and you can see multiple perpendicular lines or horizontal lines going through the cortex. This what is meant by intracortical bone resorption. And you need high quality radiographs so that you are able to see these very minor changes. But here you can easily appreciate the changes in the form of resorption of the terminal phalangeal tufts and intracortical bone resorption, as you can see here in these magnified images. After treatment, this is before treatment, you see the intracortical erosions, and after treatment, you got some resolution of these erosions. One of the manifestations is what's known as the salt and pepper skull. Resorption of the bone from the skull will result in small areas of radiolucences that are intermingled with areas of bone sclerosis, resulting in this appearance, which is known as the salt and pepper skull. And also, you may look, if you have the chance to see the teeth, you may look for the changes in the lamina dura as well. And one of the manifestations in the spine is known as the Roger-Jersey spine, which means that the vertebral end plates are sclerotic and the central part of the vertebra is porotic. And bone sclerosis is evident in the secondary and the tertiary hyperparathyroidism. It's not an evident feature of the primary hyperparathyroidism. Then there is decreased bone density in the middle part of the vertebra, and there is osteosclerosis of the end plates, resulting in this Roger-Jersey spine with the presence of calcium in the soft tissues as well. Whenever you have the bone scanning, you got what is known as super scan, which means that there is increased intense uptake in the affected vertebra. And this is a classic appearance by plain X-ray of the Roger-Jersey spine. This patient had end-stage renal failure, and the lateral X-ray showed the typical sclerosis of the vertebral end plates and rarefaction of the vertebral body. This can be also appreciated in MRI, where you see the sclerotic end plates as low signal in the T1 and T2, and the vertebral body is of intermediate signal in the T1 and T2. This is also Roger-Jersey's spine in this patient, who is HIV positive with lymphoma. The vertebrae showed in the X-ray, it showed the typical appearance of Roger-Jersey spine, and the sagittal reconstructed image also show the similar changes. Soft tissue calcification can be seen in the vessels and along the ligaments and tendons, and also in the cartilage. And this is an example where you see calcium at the insertion site of the supraspinatus tendon, which is non-calcific tendonitis, and can be easily appreciated in the plain film compared to the MRI. And this is one of the findings. One of the findings also of hyperparathyroidism is the brown tumor. The brown tumor is slightly more frequent in primary than in secondary hyperparathyroidism. But consider that secondary hyperparathyroidism is more common than the primary hyperparathyroidism. Then you will see brown tumors in the secondary type more common than in the primary type. What is the brown tumor? In chronic renal disease, there is excessive excretion of calcium in urine, and this will result in lowering the serum calcium level, and this will stimulate the secretion of the parathyroid hormone, which will result in increased osteoclastic activity to remove calcium from bone towards the circulation. Then, in certain parts of the bone where there is rapid bone loss, hemorrhage, and granulation tissue, this will result in the formation of what's known as the brown tumor. The brown tumor is an osteolytic area at the site of aggressive osteoclastic activity with hemorrhage and vascular proliferation. The name brown is from the presence of hemosiderin inside this tumor. But if you look to the skeleton, and you will see an osteolytic lesion with a sclerotic margin and the expanding nature with maybe with internal trabeculation, that it will go into the differential diagnosis of phygnomachic, as you remember from the expanding benign lesions in the bone, and this is the abbreviation for the list of expanding lesions in the bone. One of them is the brown tumor of hyperparathyroidism. Then this lesion is well-defined, osteolytic. No periosteal reaction, is usually hypervascular on angiography and increased uptake on bone scan. The diagnosis depends mainly on the clinical picture, and brown tumor may be multiple. You see one here in the right hand, and another one in the left hand, and the third one in the proximal part of the humerus. The appearance of brown tumor on CT is the mixture of blood and fibrous tissue, osteolytic lesion, slightly expanding with well-demarcated cortex, and if you inject contrast media, the lesion will enhance. And if you perform an angiography, the lesion will appear hypervascular, and in bone scan, it will show intense uptake. And this is the appearance of brown tumor in the plain X-ray, in the T1, and in the T2. It is almost indistinguishable from fibrous cortical bone defect non-ossifying fibroma, but the differentiation will depend mainly on the clinical data and the laboratory findings. And here you see an expanding lesion in the ramus of the mandible, another lesion in the right maxillary antrum, a third one in the left antrum, and this is the follow-up image after treatment, after parathyroidectomy, with regression of the lesion and the development of internal calcification. And here, multiple brown tumors in the facial bones. This is one, two, three, four lesions in the facial bones in a patient with hyperparathyroidism. Uremic osteodystrophy is the combination of osteomalacia and the secondary hyperparathyroidism in adults, in rickets and secondary hyperparathyroidism in children. Then you got the secondary hyperparathyroidism in both. If this patient is adult, you'll see changes of osteomalacia. If a child, you'll see changes of rickets. The major manifestations are seen in the spine, and the Roger-Jersey spine is one of the classic manifestations seen in uremic osteodystrophy. And beside this, you got salt and pepper skull, and you got subperiosteal newborn resorption. You may got soft tissue calcification, looser zones, brown tumors, all the manifestation that can be seen here. Then this patient with typical Roger-Jersey spine, and you see sclerosis of the end plates and rarefaction of the vertebral body. Thank you very much. Alhamdulillah Rabbil Alameen. Next time we'll have the second part of this